I'm just drawing a capillary here actually. This is a normal blood capillary. And what I want to do is use this physiology to explain the possible causes of edema. As we know, blood enters from an arteriole at the arterial end of the capillary, goes through the capillary. Here we have some red blood cells going through the capillary. They're biconcave discs, of course. Darker on the outside and lighter on the inside. And then we see here that the blood leaves the capillary into a venule at the venous end of the capillary. And I've been thinking about edema. I think there's only 4 possible causes of edema. And I think this can explain all 4 possible causes. But let's just carry on with the diagram a little longer. There we've got the capillary. Here we have the tissue cells that the capillary is perfusing with blood. The capillary going through a group of tissue cells. And we also know that there are lymphatic vessels in the interstitial spaces, the lymphatic capillaries, draining away excess tissue fluid and any proteins which manage to escape from the capillary. And we know that tissue fluid forms at the arterial end of the capillary because the hydrostatic pressure, the blood pressure in the capillary, is greater than the osmotic pressure. The osmotic pressure, remember, is generated largely by the presence of the plasma proteins. So there are plasma proteins. And at the arterial end of the capillary, the hydrostatic pressure pushing the water out is greater than the osmotic pressure sucking the water in. So tissue fluid is formed at the arterial end of the capillary because the hydrostatic pressure is greater than the osmotic pressure. At the venous end of the capillary, the osmotic pressure is now greater than the hydrostatic pressure, greater than the blood pressure in the capillary, because the blood pressure in the capillary has dropped as we near the venous end of the circulatory system. So that's what happens normally. Now, the first possible cause of edema is that there is an increase in the pressure of the blood in the capillary. So if the pressure here, especially at the venous end, is increased, that means that the tissue fluid which has been formed at the arterial end of the capillary and bathes the tissue cells, it means that the tissue fluid is no longer able to get back in because the pressure in here now is greater and is tending to keep it out, tending to exclude it. So the tissue fluid is normally reabsorbed because the osmotic pressure is greater than the hydrostatic pressure pushing out. But if the hydrostatic pressure, that is the blood pressure pushing out, is greater, then I think you can probably see that it's going to be harder for the water molecules to get back in. So any condition which increases the blood pressure within the capillary is going to reduce the reabsorption of tissue fluid and can therefore cause edema. So anything causing venous hypertension can potentially cause edema. So this capillary must drain into a venule. The venules must drain into larger veins. And if the valves in those larger veins have been damaged, for example, if the patient suffered a deep venous thrombosis in the past, the valves in the veins might be damaged. The veins will then be incompetent because the valves are incompetent. And that means the blood will pool in the veins. That will increase the pressure of the blood in the veins. And that will dam back to the capillaries, increasing the blood pressure within the capillaries, preventing the reabsorption of tissue fluid. So there could be a localised cause of chronic venous hypertension, or indeed acute venous hypertension. That's one reason you might get limb swelling if there's an acute deep venous thrombosis. You may get edema in the limb because there is an acute venous hypertension in that limb, because the blood can't get back past the blood clot. So the blood is all dammed back in the venous system, increasing the pressure of the blood in the capillary, reducing the reabsorption of tissue fluid. Or there could be a systemic cause. For example, in congestive cardiac failure, the heart is unable to pump out the blood which is returned to it in the venous system. If it can't pump out the blood that comes back, that means the blood dams back in the venous system, and that also causes chronic venous hypertension, causing congestion in many organs and in the limbs. So many organs, for example the kidneys and the liver, can become congested, but also we can see the edema as a gravity-dependent edema. It can affect the lungs, causing pulmonary edema, but very often, because it's gravity-dependent, we often see it in the ankles, and the patient gets swollen ankles. But the cause is that there is a chronic venous hypertension centrally, that dams all the way back to the capillary, that increases the blood pressure in the capillary, that prevents the reabsorption of the tissue fluid, resulting in edema. So that's one possible cause. And there's a useful clinical tip here as well. If a patient's got an edematous leg, we should always look at both legs side by side. Because if the pathology is just in the veins in one leg, then maybe only one leg will be swollen. But if the pathology is systemic all over the body, then we're going to see the swelling in both legs. So it's a very important clinical observation. Is the swelling in one leg, which may have a localised cause, or is the swelling in both legs, which may have a systemic, more generalised cause? So that's the first possible cause, increased capillary pressure. Now we've noted that the reabsorption of tissue fluid depends on the osmotic suction pressure generated by the plasma proteins. We need the plasma protein osmotic pressure to suck the tissue fluid back in. So if for any reason there is a reduction in the amount of plasma proteins, that's going to reduce the osmotic pressure of the plasma. And that's going to mean that there's no suction effect to suck the water back in. That means the tissue fluid is not going to be sucked back into the capillary. That means it's going to be left in the interstitial spaces, and that can give rise to edema. And you might have seen these horrible, wretched pictures of poor children with their tummies all blown out when they're severely malnourished. That's because these children, tragically, are hypoproteinemic. They don't have enough protein in their blood. And that's because they haven't had enough protein to eat. That's reduced the osmotic pressure of the blood, and because there's massive vasculature in the abdomen, a lot of tissue fluid forms which is not reabsorbed, and they get these horrible blown out tummies. And they also get edema in other places as well, purely through malnutrition. So anyone who's not getting enough protein won't be getting the amino acids into their blood. That means their liver can't make the albumin, because albumin of course is a protein, and if there's not enough albumin, you don't have the osmotic pressure to suck the water back in. You can also get this with malabsorption syndromes, if someone is not able to absorb the protein that they're eating, probably due to some gastrointestinal disease. You can also get it if the kidneys are excreting protein in the urine. Are the kidneys supposed to excrete any protein in the urine? Well, of course not. Urine is supposed to contain no proteins at all. But if a patient has nephrotic syndrome, the kidneys become leaky and will start leaking protein out into the urine. And this can become significant enough to cause a hypoproteinemia with consequent edema. And we've mentioned that the liver takes amino acids from the blood and forms them into proteins. It forms them into albumin, the main plasma protein. So in liver failure, the liver may be unable to perform this function. So despite there being enough protein in the diet, in liver failure, the liver may not be able to synthesize the amino acids that it is supplied with into the plasma proteins. Again, meaning there is a deficit of the plasma proteins, a hypoproteinemia. So edema can be caused by increased capillary pressure or reduced amounts of protein in the plasma. Now, we know that about 90% of the tissue fluid that is formed is reabsorbed into the venous end of the capillary, but about 10% is absorbed and drained through the lymphatic system. And as well as that, the lymphatics absorb any protein which has escaped into the tissue fluid. And it's particularly important that any proteins are drained from the tissue fluid. Now, why is it so important that proteins are not left in the tissue fluid? Why is it so important that proteins are drained from the tissue fluid? Well, the answer is that if proteins are left in the tissue fluid, that is going to increase the osmotic potential of that tissue fluid. And that's going to attract more water. So if proteins are left in the tissue fluid, that's going to increase the osmotic potential of the tissue fluid, meaning edema is very likely to occur. So it's absolutely vital that the lymphatics drain away any proteins which have escaped, so these proteins are not left in the tissue spaces. But if there's any obstruction in the lymphatics, if for any reason the lymphatic vessels are not working properly, if there's a reduced lymphatic drainage, then that means that the proteins and the tissue fluid cannot get back into the systemic lymphatics, so they can ultimately be drained into the venous system. So the proteins need to be taken away, and 10% of the tissue fluid that is formed needs to be taken away by the lymphatics. If the lymphatics are obstructed, that can't happen. Now, this can be primary. Some people are just born with poor lymphatics. There's a tropical condition where worms can lodge in the lymphatic vessels. That can cause gross swelling, so-called elephantiasis. There can also be tumours in cancer. If there's a tumour, that can press on the lumen of a lymphatic vessel. Or a tumour can even spread into the lymphatic vessel itself, blocking off the lymphatic vessels. And very often we see reduced lymphatic drainage as an iatrogenic complication. What does iatrogenic mean? Remember that one? Well, iatros is Greek for doctor, isn't it? So iatrogenic means something caused by medical treatment. So, for example, a patient might have had radiotherapy, which has caused fibrosis in the lymphatic vessels. Or after breast cancer, for example, a patient may have had some axillary lymph nodes excised, reducing the lymphatic drainage capacity of the lymphatic system. So reduced lymphatic drainage can also cause edema. So edema can be caused by increased capillary pressure, decreased plasma protein, reduced lymphatic drainage, and I can only think of one more actually, and that is if you get increased capillary permeability. So if inflammatory mediators act on a capillary, the capillary will vasodilate. So imagine that my hands are the endothelial cells in a capillary. If there's vasodilation and the capillary gets wider, that's obviously going to increase the size of the gaps between the individual capillary cells. And also in inflammation, the very capillary endothelial cells themselves contract. They get smaller because there's actually a contractile cytoskeleton, little microtubules inside the cells, actually made of actin and myosin, just the same as in muscles actually. And this microtubule structure inside the cytoplasm of the cell will contract getting shorter in response to the presence of inflammatory mediators. This means the cell gets smaller, and if the cell gets smaller, I think you can see that that is also going to increase the size of the gaps between adjacent endothelial cells. So in inflammatory processes, there's vasodilation to increase the size of the gaps between the capillaries, and the cells themselves actually contract and get smaller, also increasing the size of the gaps. And if you increase the size of the gaps, you increase capillary permeability. This lets more fluid out of the capillary into the tissue space. It also allows some proteins out, which will increase the osmotic pressure in the tissue space. And it's important to remember this can be a completely physiological process. Edema is a clinical feature of inflammation. Remember the clinical features of inflammation? Heat, pain, redness, swelling, loss of function. This accounts for the swelling. And it's good in inflammation because it lets more nutrients out into the tissue fluid so that the cells can repair or regenerate. So edema can be a complication of inflammation. And it can also occur in sepsis. If there's a severe infection, you can also get the vasodilation. And the third cause of increased capillary permeability that you might come across is allergic reactions. You can get swelling as a complication of allergic reactions. Well, they're the four causes of edema I could think of. Increased capillary pressure, decreased plasma protein, reduced lymphatic drainage, and increased capillary permeability.